Good morning.
Good morning. How are you?
I'm great and yourself?
I'm here.
Ah,
I feel like the color purple. I'm here.
it
How's your week?
it was all right. How about yours?
It was good. It was good. Busy. Busy. It's a
Oh,
lot.
okay.
Uh, I guess that's a good thing to be. It
Yeah.
should be a blessing and a good thing to be. And I guess I need to look at it from that particular perspective. But I'm tired, y'all. I'm tired. I'm tired. Tired. All right, all right. Let's see. Okay, trying to make sure everything is everything. All the things are all the things here in these streets. All right, all right. Well, welcome everybody to our Saturday morning tea where we discuss health information, news, education, certification tips and entrepreneurship, the revenue cycle at large. The government, because the government is governmenting. And as you come in, don't forget to like, uh, hit that like button and or the thumbs up, depending on whichever platform that you are watching us from. I am Clarice Warner. I am the Girl with the Pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, the heart of it all, that specializes in revenue cycle, revenue cycle, and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Well, if you don't, before I introduce my co host, let me share with you some information. Let me put you up on game on a free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Oh, so if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then check out the video description for the link if you missed the information in the little video. So joining me today is my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for 30 years. In 2014, I left the bedside and transitioned into medical coding. And during the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other healthcare professionals with a clinical background transition into the wonderful world of HIM.
And isn't it so wonderful? I
It
just want to sing a
is.
little jingle. The wonderful world. It's a wonderful world. A wonderful world. So, how's everything been going?
It's been going.
Okay.
I have my last class on Tuesday, and I'm ready. I need a break.
Uh oh. You breaking and I'm starting up. So, yeah.
Ah,
I get to play in the whole foolishness now. It's my turn. I'm up on deck. All right. Let's see. Let's see. Um, Good morning, Alanda. Happy Saturday. Happy Saturday. Good morning, Renita. Good morning, Carolyn. Good morning, Tanika. Good morning, everybody.
Good
Good morning,
morning,
everybody.
everybody.
All right, all right. So I feel some comedy coming. Not as much comedy as last week. Let me just say that, but I do feel some comedy coming in my spirit. So let me get it out. And I'm laughing at myself I have my tea, I have my water, but I feel like I'm in the mellow moods hour or something. I don't know what's going on.
Uh-oh.
I don't know what it is. I just feel like it's real quiet. Nothing is going. It's not raining. It's rainy, but not raining. But it's real quiet.
Well,
It's
that's good.
spooky. Maybe is it the calm before the storm? I'm nervous. I'm nervous. Wait a minute. What you got? I saw a whole spoon.
This is, listen, I got a whole story. I got to lay off the energy drink, so I'm trying coffee. It ain't working, but
Not
it's,
I'm trying. Sorry, it's tea. Not I'm trying coffee.
it just don't give me what I need.
Sir. See, I did not tell y'all the comedy was coming. I felt it in my spirit. Okay. So before we jump in, let me remind everybody that this is a conversation and you can join in and add to that conversation. So don't be shy. Don't be shy. Your opinion is welcome and it matters. It matters here. So you can use the chat. If you have a question, just make sure you put a Q in front of it so that we know it's an actual question for us and we don't miss it. But we will play around with all the foolishness that comes in through the chat. So feel free to have at it. For those who are joining us today, we are giving you some healthcare insights on March being National Kidney Month. We talked about Women's History Month last week, but we got some other stuff that's going on in March as well, and one of them is National Kidney Month. A fraud case that's going a fraud case that's very, very interesting, very, and some whistleblower revelations. I know there's folks with us who love nothing more than hearing all about the whistleblowers and how they can join the ranks. So we're going to talk a little bit about the whistleblowers. But first, let's get into some church announcements, shall we? Yes, yes. Be like, all are welcome. Come on in. Come on in. Have a seat. Have a seat. Make yourself comfortable. Get you some tea or coffee, but tea. All right. So today, turn this down. The church announcement I had two. Well, actually, one of them is Mr. Jesse's church announcement. So we're gonna talk a little bit about this cyber hack, this cyber attack that hit Change Healthcare, who is, I think, part of United Healthcare, if I'm not mistaken. And so they got arms everywhere in all kinds of places. But then I heard there was the folks behind the hack had a ransom, and somebody paid the ransom.
Yeah.
$22 million. Okay. So, okay. One of the things you said, yes, United Healthcare owns them. Hey, Crafty Coder. And good morning. Good morning. Oh yeah, you got information about the energy drinks are not good. They are not, but that's a whole other conversation, sir. But anyway, so yeah, this thing going on with Change Healthcare has prompted the Department of Health and Human Services to issue a statement regarding this whole cyber attack, and they want to know that they're putting together some additional flexibilities for them. They're also letting them know they're here to help assist all providers in continuing to serve their patients. I heard somewhere one of the they didn't get deep into their system, but they got into their scheduling system. But they were able to shut it down before they could do any particular damage. But some folks got hit, I guess, rather hard. Mr. Jesse, were you part of this experience here?
No, ours was last year.
Okay, so you were already you already knew what to do, or you already were prepared. So HHS is committed to help all healthcare operations across the country avoid these types of disruptions in healthcare, period. And so they have teams of working on this, including the FBI. They have a Cybersecurity and Infrastructure Security Agency, or CISA. Of course, the White House is involved, and all other agencies are here to assist. So one of the things they said, that Medicare providers needing to change clearinghouses that they use for claims processing during these outages should contact their Medicare Administrative Contractor, or MAC, to request a new electronic data interchange, or EDI, enrollment for the switch. The MACs will provide the instructions based on the specific request to expedite the new EDI enrollment. And CMS has instructed the MACs to expedite this process and move all provider and facility requests into production and ready to bill claims quickly. CMS is also strongly encouraging other payers, including state Medicaid and the Children's Health Insurance Program, or CHIP agencies, and Medicaid CHIP managed care plans, to waive or expedite solutions for this requirement as well. CMS will also issue guidance to Medicare Advantage organizations and Part B sponsors, encouraging them to remove or relax prior authorization, other utilization management, and timely filing requirements during these system outages. CMS is also encouraging Medicare Advantage plans to offer advanced funding to providers most affected by this cyber attack, because it did hit some folks in the pocket and they couldn't bill. And so that means they couldn't get money and all of the things that come with that. CMS also strongly encourages Medicaid and CHIP managed care plans to adopt the same strategies of removing or relaxing the prior authorization and utilization management requirements, and consider offering advanced funding to providers on behalf of Medicaid and CHIP. If Medicare providers are having trouble filing their claims or other necessary notices or other submissions, they should contact their MAC for details on exceptions, waivers, or extensions, or contact CMS regarding quality reporting programs. And lastly, CMS has contacted all of the MACs to make sure that they are prepared to accept paper claims from providers who need to file them. While they recognize that electronic billing is preferable for everyone, the MACs must accept paper submissions if a provider needs to file claims in that method. They are also stating that this incident is a reminder of the interconnectedness of the domestic healthcare ecosystem and of the urgency of strengthening cybersecurity resiliency across this ecosystem. They said they also released a concept paper in December that talks about the cybersecurity strategy for healthcare. So if folks need to go back and check that out, the link to this particular article is in the description box. Mr. Jesse, did you have anything you wanted to add to this?
Yes.
All right.
Just wanted to, well, first I want to say I'm not surprised that Change Healthcare got hacked, because they were kind of loose with their, with their technology anyway, because moving forward, people are going to have to start issuing equipment. They don't issue equipment. You use your own personal equipment to log in. So, the easiest way Like it does. You could have $1 billion cybersecurity system, but if somebody opens up something, they have the business opening, and they get into your system, they're already in, so it doesn't do anything.
Yeah.
And I'm sure that's how it happened at our company, and I'm sure that's how it happened at Change Healthcare. So I don't know what they're going to have to do on the user end to really get people to, to stop. Well, I know what my company does is they randomly send us fake emails. And if you click on 3 in a year, you get fired.
Oh, wow.
And the first time you do it, you have to take a course. The second time you get a reprimand, and the third time you're terminated.
Wow.
So
Now, did they send you equipment to do your job?
Yes.
Okay.
But Change Healthcare didn't when I worked for them. I used my personal laptop. But my job that I have now sent me equipment.
Yeah, most organizations that I know that have remote employees actually send them the laptop or computer or all of the things. And in some instances, they set up a whole separate like internet network. And folks, I know a couple people who work specifically for an organization, and like she has her home internet and then she has her company set up internet, so there are no problems, no issues, no outages. If it's an outage or whatever, it's with the organization, not with her personal. So they have a whole thing set up over there. I know everybody's not that sophisticated, I guess, if you will, but yeah, that's how they rolling over there. Yeah, that's a mess.
It's just low hanging fruit, and I don't know what the answer is going to be, but it's very common, and they always go in through email.
And that's why they tell you, do not click on any strange links. If you didn't ask or request for something and somebody is sending something to you, do not hit them links. Be like,
Well, they have gotten sophisticated because they've even sent test emails with my supervisor's name on it.
Wow.
Because they like at my company, they don't want you to click on anything. They want so I don't. If it's not something, well, first of all, I hardly ever use my work email. It's so, and when I go through my inbox, if something doesn't look right, I just click on it, and then they'll write back and say this is okay, fine.
So is there a way for you to send something to them to say, can y'all verify the validity of XYZ?
You have a button. You just click on phishing alert, and the email automatically sends.
Nice. Well, that's good, because that will allow them to help track any of the foolishness that may be going on. Yeah. She said, I don't click nothing at work or home. Yes, processing times are about to triple. You already know. Like, oh Lord, relax prior authorization. Well, there's a whole big battle about this prior authorization going on. So I'm sure we'll definitely hear more and more and more about that. She said, yes, 22 million, and we still at point A. Yeah, unfortunately.
Well, actually,
go ahead. I'm sorry.
I saw a very good documentary on YouTube last year right about the time, because our network got hacked the day, like right after Thanksgiving, the day after Thanksgiving, actually. And there's a video on YouTube about this IT person in Canada from somewhere in Eastern Europe. He basically was part of this international ring that started this last year, or maybe even a year before. And when they raided his house, like he had in a closet like $400,000 in cash, and how they do their ransom is they have them pay them in Bitcoin because you can't trace it. It's really deep. And
it's a new come up, huh?
In his particular instance, because the FBI found that there was a server in one of them countries, Serbia or somewhere, that was responsible for all these hacks.
Wow. That is interesting.
It's big business because once they get the information, you don't know what they're going to do with it.
Now that right there, my friend, is the truth. The truth. And it's so much information that we have
So
in these healthcare systems. So much. I mean, so much, so much. Um,
because yeah,
that's needed. I mean, we need the information. But go ahead.
because even once they pay the ransom and they have access to their system, like then all your information they can sell it to the black market, sell it to
They
the
could still.
market and make even
They
more money.
got it. They got it.
Exactly. They have everything they
There's no
need.
turning it back. It's not like it's a piece of paper. It's like, oh well, here's your paper, whatever. No, it's you. They've got you. They've got it. Because then quietly it can continue. Because yeah, you paid the money to get your system back, but did you pay the money to get the information back? No, you can get the information. So if you don't send us another $22 million for XYZ, then we're gonna then sell your information here or do whatever malicious things that they can come up with to do. It's crazy. It's crazy. Yes, it's very, very scary. Very scary. Yeah. They done hit a vulnerable spot within healthcare. All right. Well, that was that church announcement. My other church announcement, and let me just preface this because this will probably be my video this week. I just need to ask, and nobody needs to answer in this forum. You can think in your head, yes, I do. No, we don't. Whatever. But you don't need to answer out loud. Not even in the chat. Don't say a word if this pertains to you. So, are you working in a hospital system that provides their employed staff for private physicians that may be doing surgeries or other services in your hospital facility? That seems to be a very, very common, she got the dots in the eyes. That seems to be a very, very common practice in a lot of facilities where, Dr. Jones from the community is, a cardiologist and does a lot of procedures. And of course, a lot of these procedures are inpatient procedures. And folks are wanting him to bring their patients into their facilities. Well, when he comes in and brings his patients into your facilities, referral i.e., he's bringing business to your hospital. You hospital provide your staff to this physician who doesn't have a contract, not employed by you, they just private out there bringing you a referral. It's a little slippery slope, according to the government. And there's a whistleblower case. and folks then got paid. So folks are scrambling to figure out what they need to do to change these particular practices, especially when they're providing employed nurse practitioners, employed physician assistants to assist in the surgery or assist in the procedures. It's a whole thing out here, y'all. And I told y'all the government is out here governmenting. So I will have more on this particular case this week in my video. So hold on, stay tuned. The whistleblowers are out here. You talk about these cyber hackers, these whistleblowers out here making a come up as well. Yes, you are absolutely correct, Landslide, because there are a lot of people that operate in this model. And it's like, oh Lord, what we gonna do, Harpo? What we gonna do? So be prepared. All right. That's our church announcements for today. Mr. Jesse, did you have any additional church announcements before I
No.
get into our... Let me get rid of our music. Okay. Well, let's get into I do want to make sure we have time for the National Kidney Month, because I love that article. I was like, I wish I had time to do it, because that was fabulous to me. I love. So we're gonna really dive into that. So real quick, Um, let's talk about this doctor who has pretty much lost his mind. Anyway, um, the Department of Justice.
Wait, before you start,
Yes, sir.
Crafty Coder had a question. I just wanted to address it. It doesn't cost anything, Crafty Coder.
Excuse me.
It doesn't. You just have to find an attorney and give them your proof, and they will file a case. And then once it gets into, I think it's the Federal Register or somewhere, the government will look at it, and if they want to take it on, they'll take it on. But you don't have to
Yeah,
pay.
the government has to decide whether or not they take it on. Because one of the ones that we're going to talk about today, they did not, and so, but, even if they don't take it on, there's still an opportunity for a civil case if need be. She said, "Bet Lord, we're gonna have our on the street correspondent doing some things." She said, "Say way less."
Look,
Oh my God.
it protects your
I
program.
she only gonna show up in the meeting after the meeting.
So she gonna have to assume a new life as an Amish biller.
Oh my God.
Her name was gonna be Sarah.
Didn't I tell y'all the comedy was coming? I told you I felt it in my spirit. I felt it in my spirit. Oh Lord. Okay. So, this next case, there was a doctor in New Jersey who has agreed to pay nearly $700,000 to resolve allegations that he submitted false claims to, of course, federal healthcare programs. Yeah, yeah. And dude was just reckless. I mean, reckless. Um, says there are three sets of allegations from January 1st, 2027 to June 1st, 2022. Um, the defendant regularly upcoded certain CPT codes typically used to report more complex services or services longer in duration related to the evaluation and management of patients. Of course, upcoding is alleged fraudulent medical billing in which a claim is submitted for payment regarding a service that is more expensive than the service that was performed. Wait a minute, let me see. His medical practice is Preventive and Diagnostic Medical Center of PA. Um, I want to see. He was also the former medical director at the New Jersey Veterans Memorial Home in New Jersey as well. So that's one claim about upcoding. The other thing is, and I learned a new term, impossible days. The defendant knowingly submitted claims to Medicare for services that Dr. Sangal, hope I'm saying his name right, Arun Sangal is his name, um, did not provide to the patients by regularly billing for impossible days. An impossible day occurs when a physician purports to provide such a high volume of services or procedures in one day that there is no way the physician reasonably could have performed them all. This is the low hanging fruit when they ask you about your schedule. When they can just look at, I mean, they don't even have to look at anything. Let me see your schedule and let me see what you did. The time, the math doesn't math. So they said, for example, uh, on March 2nd, 2018, the time associated with CPT codes built by the defendants for services that Dr. Sanghal provided exceeded 43 hours. Make it make sense. And then he also allegedly purportedly to provide services to Medicaid beneficiaries in New Jersey on days when he himself physically was not in the United States. Yeah. Mr. Jesse, you have any?
Mm-mm. That's just crazy.
Wait. We got some tea. My last place, the doctor is in jail. All right. Wait a minute. Wait. She said the shade. The shade. Yes. The shade. Because really, I don't understand. I don't understand. When will they learn? When will they learn? When will they learn? And then the last one that we're going to talk about is Aledade, which is the largest U.S. independent primary care network. A whistleblower has accused them of Medicare fraud. Um, this is the case. I don't believe that. Um, I don't think the government took the case on, which is how the whistleblowers um information and name and stuff has gotten out. But they are still, but um the opportunity still does exist for additional action because they're still reviewing and investigating. However, it says that, let's go back. Um, it is alleged that they cheated Medicare out of millions of dollars using billing software that was rigged to make patients appear sicker than they were. So this is now a civil suit that alleges that Aledade incorporated billing apps and other software and guidance provided to doctors improperly boosted revenues by adding overstated medical diagnoses to patients' electronic medical records. Um, According to the suit, it says Aledade did whatever it took to make patients appear sicker than they were. It said they turned anxiety into depression, which could boost payments by a little over $3,000 a year per patient. They also decided that patients over 65 years old who said that they had more than one drink per day now had a substance use issue. And this too could bring in over almost 4,000 extra dollars per patient per year. Um, the whistleblower case was filed in federal court in 2021, but remained under seal until January of this year. It was filed by Kushwinder Singh. I hope I'm saying his name right. Who was a senior medical director of risk and wellness product at Aledade. So he actually worked with the company, and they fired him after he objected to its quote fraudulent course of conduct end quote. Again, he has declined to comment on the suit. Case is still pending, and the organization has yet to file a legal response. Um, Adelaide is one of hundreds of groups known as accountable care organizations, and this is the accountable care organizations enjoy strong support from federal health officials who hope they can keep people healthier and achieve measurable cost savings. Um, so yeah, this company has grown rapidly behind hundreds of millions of dollars in venture capital financing and is valued at $3.5 billion in 2023. The chief executive officer also declined to be interviewed. Um, they're not responding, etc. So the lawsuit also names as defendants 19 independent physician practices. So there's more to come. Many in small cities in Delaware, Kansas, Louisiana, North Carolina, Pennsylvania, and West Virginia. And according to this suit, the doctors knowingly used Adelade software to trigger illegal billings, a practice known in the medical industry as upcoding. Yeah. So that's another whistleblower suit out here in these streets. Um,
I have a question.
yes, sir.
These affordable care organizations, Do they operate under any other kind of payment model other than risk adjustment? Because those are the only hear of accountable care organizations in risk adjustment. Is there another type?
I don't think so because I think they were the one of the first ones to dive into the whole risk adjustment model.
But I don't, and that ties back to what we have been talking about forever. And I can, having worked in risk adjustment, I don't know why these people. It's so easy to get caught. Like that. All you have to do is just look for meat. That's all. And I mean, a brand new coder could audit that because, well, I don't know about that, but you know, but it's just easy to spot. I
It's
mean,
easy to spot. Yes, lack of common sense. You're absolutely correct. But the thing is, um, with these systems, that's problematic as well. Um, because I remember back in the day, I'm about to date myself. Back in the day, there was a system that will remain nameless. Um, that was in the ED space, and you have your evaluation and management codes that are uh, used by your physicians and practitioners. And then hospitals would also use um, evaluation and management codes to level, or not necessarily level the services, but to determine um, the amount of resources that were used in certain settings. ED was one of them. And unlike the evaluation and management guidelines and guidance that we had to level the services for providers, it was a whole free for all for these hospital entities to determine what would be a level one or level one service versus two, three, four, five. Um, but then you had this wonderful to the rescue put on a cape company that said, "Oh, well, we can help you. And if you do this, that, and the third, it'll bring your billing here. And if you do this, that, and the other, it'll bring your level of resources here. If you count however many people that are involved, if you look at, just all kinds of stuff that they were throwing in this mix. Now, again, each organization can level at the time, we're able to level individually. So again, there was no set rule that everybody had to follow. You make your own recipe to make this cake. Um, and compliance got wind and word, and it became a whole deal. Like, whoa, 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 whoa. If we continue we audited this stuff for years. Like, no. Well, they said we could do when they come for you, they're not coming for them. They said again the guidance that they provide for you to use their systems and their services, and folks get caught up with feeling comfortable with the advice or information that they get from the software company who is trying to entice you to use their service. They go away and you're stuck. So be ever so mindful and careful when you are adopting the quote unquote guidance or advice from a lot of these systems. Because again, unless somebody then sues them or puts a claim against them, they just out here.
but this ties in. This goes perfectly with everybody seems to be paranoid about AI. Same thing. Like
Mm-hmm.
you just people don't have it. People shouldn't fear AI because of this very thing. And I've talked about how where I work, they have auto suggested codes that are generated by AI because that's all it is, an algorithm,
Right.
and it and they're inappropriate. But I know they're inappropriate because I know what I'm doing. But what if there's other people who just, and I know that there are people.
There are plenty of people who do not, and that was the thing with this particular company and organization, because they were just, oh well, this is what it spit out. It has to be right. This is what they said. This is what we need to build. Slow down, Buttercup. No, absolutely not. Absolutely not. That's right. She's absolutely right. It's about what you knew or should have known. Because at the end of the day, that provider has attested to the validity of that claim. Period. Not the software company, not the tools that they've used to do whatever. That's a whole other conversation, especially if we talk about hospital and uh, the 3-day rule and all of the things. It's not the tools, it's not whatever. It's you. All right. So those were the two I wanted to bring up that came through. Now let's get into. I want to make sure we got enough time for this, because I thought this was the cutest article ever, and I wish I would have had time to do it, but it was just so cute to me. So, an article from Lori Johnson, where she talks about March bringing in National Kidney Month, and the Office of Minority Health announced that March is now National Kidney Month. Chronic kidney disease affects 14% of adults in the United States. Risk factors include hypertension, diabetes, obesity, and heart disease. The Office of Minority Health also states that Black Americans are more affected by the disease at 20%. Asian Americans and Hispanic Americans are also affected by chronic kidney disease at a similar rate at 14%. And then she goes into the coding. And this piece here, I just thought was so cute, because while everybody wants to point folks to the electron or the encoder or whatever, she went old school. If you go to your index, if you turn the page and look, that was the thing that got me, because I was like, I wish I would have had time to do this, but she took it back to the old school. So let me share my screen here. Whoops. Okay. So here she talks about the coding of chronic kidney disease. So you're going to get a little coding lesson today. Thanks to Miss Lori Johnson. Lori Johnson. Look, I want to make sure I didn't butcher her name. So coding for chronic kidney disease can be found in Chapter 14, Diseases of Genitourinary System, and the codes begin with an N. N is in Nancy. This condition is affected by the office official coding and reporting guidelines, IA 15, or 1A15, I'm sorry, with. The guideline states the word with or in should be interpreted to mean associated with or due to when it appears in a code title, the alphabetic index, either as a main term or subterm, or an instructional note in the tabular list. Do you see those things when you were in a encoder?
Absolutely not.
Okay. I just like I said, this was going back to the old school. So, the classification presumes a causal relationship between the two conditions linked by these terms in the alphabetic index or the tabular list. So in the 2024 ICD-10-CM index, again, this is what you see in your book, it shows the following options for kidneys disease. Now, the first thing you need to know when you're coding these is you need to know the stage. And the stage should be specific in the code assignment. So you see the stages here. The next step is to identify any related conditions. So is it hypertensive? Is there a pregnancy? And this word that's gonna make me butcher everything I've ever thought about today, but we're gonna attempt it. We're gonna attempt it. Um, Schistosomiasis. I think I said it right. um, and then if the patient has hypertension of chronic kidney disease, then the coder is instructed to look at the entry of hypertension kidney. See, hypertensive. See, hypertension kidney. See how it all works. Well, that's a whole other lesson. We got we got all the things, but that's a whole other lesson. We don't have enough time for all that today. Reach out to Mr. Jesse or myself if you need that additional training. Anyway, so it says to go to hypertension kidney, and then in the index it displays this information. So under kidney, you have I-12.9, and then you have with, and then if it's heart disease, if it's chronic kidney disease, etc. So if the patient has stage 3 chronic kidney disease and hypertension, then the coder would assign I-12.9. The coder should open the ICD-10 CM tabular volume 2 I-12, which shows the following information. Okay, I need to get closer because it's teeny tiny. Hypertensive chronic kidney disease includes any condition in N18 and N26, I think it says, due to hypertension, arterial sclerosis of kidney, arteriosclerotic nephritis, chronic or interstitial hypertensive nephropathy, and nephrosclerosis. You also have excludes. So all of this is guidance to help you to arrive to the appropriate diagnosis code. In the tabular volume under I-12.9 directs the coder to also assign a code from N18.1 through N18.4 or N18.9 based on the chronic kidney disease stage. You see that here. Okay. In this case, the coder would assign N18.30 as there is no further specificity. This lack of documentation would be an opportunity for provider education as well as a query to request the documentation. The tabular volume shows this information. N18.3, chronic kidney disease, stage 3. N18.30 is chronic kidney disease, stage 3, unspecified. There are other options here if you have more specific information in the documentation. If the provider documents in the patient's chart that the patient has CKD stage 3 or hypertension CKD 3A, then of course you would use the I-12.9 and then N18.31. Again, the guidelines state that the relationship between hypertension and chronic kidney disease may be assumed. So the use of preposition with is one difficult concept to understand for new coders. This concept is used when coding hypertension with chronic kidney disease. So make sure that you are coding chronic kidney disease correctly as we recognize National Kidney Month. I just thought that was the cutest article ever. Mr. Jesse.
What is so interesting is when I did my when I was getting my HEMA trainer certification, I did it on just that.
All right.
Yeah, I-12, the I-12.9 category.
Good. I'm reading. Okay. I love my books. Don't you? I do too. Nothing like a good book to help you making sure the coding is there. But I love how she outlined that in that particular article where you can actually see that. Because again, unless you know, well, you should know to verify your codes but yeah, that's a whole other conversation, right?
If you don't use a book, how can you verify?
How can you verify? You're gonna take it and run, right?
Exactly. Now there is information in the encoder that you can click on to look at.
To go to kind
But
of.
it's, but it's not like it's when you go to the tabular, it's right there. It's
Mm-hmm.
color coded and you can't miss it. And
Mm-hmm.
that's why they color code it.
Mm-hmm.
But that's what she just did is a lost art. That's like sifting flour, because
That
nobody
I still do when I bake my
see,
cake.
but see,
I'm old school.
but I mean, when you have whole entire programs that teach directly from an encoder or codify, what can
What can you do? How can
exactly?
you? Yeah. How can you do? Wow. Yes, Miss Yolanda. We do have. Okay, I don't know what a state test is, but yes, we do
Right.
have online class information. If you are looking at the description box, I don't know if she might be one of your looking from your site. I see the little link thing there. But the description box still carries over, right? Or
It
no?
should, yeah.
Okay. Well, if you look in the description box, you can find information on our online class, my online class. And if you follow Mr. Jesse, you can find information on his. Wow. But I love that. I thought that was so cute. Just
Mm,
how she put that together. It was so clear. There was a little bit of information from everything. You got to see something about the guidelines, stuff, things that folks don't even know exist, bless their whole entire heart.
no.
You got to see how you're supposed to um, look at and read the index, and then how you're supposed to go back and validate the information that you pull from the index, because you should never code directly from the index. Validate it in the tabular. It was all of the steps that you're supposed to do as a medical coder, all in
Look,
one little article. It
that
just
was
tickled my whole fancy.
that was back when they taught it the old way back in 1732.
Would you stop? But it all still applies.
Oh yeah, I mean, and causal relationships are not easy. That's why I don't understand how anybody that should be that has to be taught separately. Like,
It should be a whole section. So to your point, there's several of those guidelines that you need to pull out. Hey, we need to make sure you understand these types of concepts that are coming out, because these things don't change. They don't go away. These are some uh, tried and true concepts in this coding, in these coding streets that we deal with, that you need to know. Period. And folks don't
and
do that.
right, and you also, and it really gets deep because especially when you have hypertension, CKD, and diabetes. Because if the provider writes diabetic CKD, then you can't link it to the hypertension.
Exactly. And that's separate.
But
But
those are
you
all
need to know those things. And the guidelines will instruct you. So even if you own an encoder, you should know about checking your guidelines. Period. Yeah. Or checking that suggested code, or those suggested codes that may come your way, and validate them. How about that?
well, I did it was last year. We're required to do a certain amount of presentations each year as part of
Mhm.
our education. So I had to, so I did one and I did it on causal relationships, and um, people got in their feelings because the encoder will suggest E11.22. So I always validate everything. So I'm like, well, what's the stage of CKD? And always when it's N18.9, they still suggest it. But if you go to the tabular index under E11 or any of the diabetes 0.22s, you have to have a stage of CKD. It can't be unspecified. It can only be unspecified with hypertension.
Mhm.
And when I tell you, I thought I was going to have to fight. And then somebody was like, well, hospitals can make up their own rules. No, they can't. Look,
Who is where you get that advice from, sir and ma'am?
and I'm like, and I had screenshots. I'm like, this is what the tabular index says. It's not what I'm saying. It's right here.
Bless their hearts.
So this is why you have people who are whistleblowing and doing. That's why.
It's become a whole other stream of income for folks, if you will.
Somebody needs to come up with a whistleblower course. How to? I'm serious. I wish I knew. We need to get an attorney.
We need an attorney. Like, can you give us a walk step by step? Wait a minute. We'll talk about that at the meeting after the meeting. We may have our own little in-house attorney that we don't even know about. We'll talk about that at the meeting after the meeting.
And we can get the crafty coder. She and her husband will by their new names, Sarah and Jebediah. We can get them.
I cannot with you. I will not with you. Crazy. All right, all right. Well, we are at the top of the hour, but let me also point out that we have, I mentioned the meeting after the meeting. We have, she is cracking up. Sadiqa. Look, everybody gonna have Amish names. Keep playing. We have our Patreon where you can get additional insider tips, or we will further expand on and talk about the topics of the day. We have expert Q&A sessions. I think last week, everybody walked away with pages of notes because it was a lot of information that was being provided in our meeting after the meeting. So one of the perks that you have as being part of our Patreon is the meeting after the meeting. We also have other informative information that we share throughout the course of the week. We have a resource library. So there is the opportunity for you to actually have tangible documents that you can go through. We'll tell you, we'll share, but you know, from at least my compliance background, I need to see it for myself. So we provide you the opportunity to see it for yourself in the resource library. And of course, additional exclusive content and the networking opportunities. Even if you go underground as Jebediah and Sarah, we will allow you to still network in our meeting after the meeting. So feel free to be a part. The information is here, but also the link is in the description box. All right. And I still am going to complete the video. I just ain't got around to that. Mr. Jesse, do you have any additional comments or concerns?
No, I'm just ready for the meeting after the meeting.
Look at you. You ready to just jump on in. All right, y'all. Well, this here has been another episode of our Saturday morning tea, and we thank you so much for joining us or checking out the replay. Let me ask, was the tea spilled today? Was it spilled? Hopefully.
Absolutely.
Like I said, I learned a whole new term, impossible days. Wow.
Yeah.
I knew the strategy and I knew it was done, but I didn't know there was a term for it. Impossible days. Okay. So if this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding, as well as some entrepreneurial tidbits that we provide as well. I guess now we're going to add whistleblowers, but no. That may be something coming down the pipe. So as you leave out, don't forget to hit the thumbs up or like button again if this resonated for you. You can also leave us a comment. Tell us if this information was beneficial for you. Tell us where you're checking in from. And you can also leave us with content or things that you would like for us to discuss or talk about in the way that we love to talk about them. Also, check out the Coding Nurses channel on YouTube as well. He always has some gems over there as well. I thought I saw some chats coming in. Oh, I saw. Okay. Yes. Yes. The tea was spilled. Yes. 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 All right. All right. Well, again, this has been a great session today. Thank you for joining us. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care and have a fabulous weekend. Bye bye.